So in this video, I'm going to talk to you about why you might or might not want to have an epidural in labour. My name's Hamish. I'm a consultant anaesthetist in the UK, and anaesthetists are the people who look after you when you've got pain. Specifically, I've got a specialist interest in maternity, which means I often spend a lot of my time looking after and problem solving people who've got pain when they're in labour. Now, epidurals are just one of many, many things that you can have to solve labour pain, and in this series of videos I'm going to talk about everything from hypnobirthing all the way along to epidurals. So I'm not just going to give you the things that I would specifically do, which are often drug based, because that's not everybody's cup of tea. But in this one, we're going to talk about epidurals. So, I can't give you specific medical advice because I don't really know you, but what I can do is give you general information that you can use, such as the risks and the benefits and how you'll feel, to use as information so you can have a sensible conversation with the people who are going to look after you when you're in labour. Now, the first things first, let's have a look at the benefits. So, epidurals are generally considered the best form of pain relief you can get. And in certain circumstances, labour pain can actually be a little bit sorer than it would have been if you'd gone into labour yourself. So for instance, if you are induced, which is the obstetricians in the midwives giving you chemicals and drugs to help your labour trying to occur, or if you're augmented, which is them giving you a drug to help your contractions either occur more strongly or more frequently, often this is associated with greater degrees of pain, and epidurals can be very good at taking that away. There are other things that can occur in labour, such as an episiotomy, which is a cut to help baby's head come out. Sometimes it's necessary to stitch that up, and epidurals can help with these things because they can numb the area where these things occur. Also, if you need to have some form of delivery, like an instrumental delivery, which is forceps or the suction cup on baby's head, what we call Ventouse or Kiwi, then epidurals can make you numb for this. We can also give you a stronger version of the medication that we give you in labour to make you numb all the way up to mid-chest level, and this allows you to have things like caesarean sections and operative instrumental deliveries done in theatre without feeling any pain. There are other things that can happen during pregnancy. So for instance, some medical problems such as preeclampsia, which is a problem of high blood pressure, occasionally the obstetricians will need to treat this with various medications to try to bring your blood pressure down. Occasionally, having a lot of severe labour pain can cause big fluctuations in your blood pressure, and an epidural can smooth this out. So they can be quite useful for reducing the risks of blood pressure surges in relation to pain or delivery from preeclampsia. The last thing is that there are certain medical conditions such as heart-related problems or sometimes problems that people have within the blood vessels, etc. of their brain, and this can mean that having big swings in blood pressure can also not be particularly safe for these individual patients, and epidurals in those circumstances sometimes can be a useful thing to do. So how does it feel? Well, there's probably two ways to look at it. The first thing is how does it feel to go in, and the other thing is how does it feel once it's in. So to go in, it's a needle, so it does feel quite sharp. Now we do freeze the skin initially with a numbing drug, but that can still feel a bit stingy. Once the epidural goes in itself, it feels like a kind of sharp pressure as it goes in, and that sharp pressure can be really quite uncomfortable for some people. If there's lots of attempts needed to put it in, it probably could be interpreted as being quite sore, but for most people they're usually fairly straightforward and not too uncomfortable. Probably about similar to the pain that you would expect from having a drip or a cannula put in. Once they're in, the local anaesthetic itself, even though it's a numbing drug, doesn't really actually make you numb or make you lack sensation initially, because it's quite a weak version of it. What it does is it takes away the feeling of the contraction pain, although sometimes you can be left with a kind of tightening feeling. So, but ultimately, it takes away the labour pain. You should still have mobility and the capacity to move your legs, although occasionally it's sometimes necessary to make you more numb than that, and your legs will go heavy. Although over time they will eventually go heavy, even with the dilute version of the local anaesthetic that we use. The other thing is when people inject down through the epidural, you feel it cold going down your back because the solution is colder than you are. One of the drugs that's in it can make you feel quite itchy sometimes, although for most people that's usually fine. Some people can develop a very slight tremor when they've got an epidural, and it gives you a kind of shivery feeling like this. and often it'll work a bit better on one side. So you'll notice one leg will go really heavy and the other leg will be fine. But for the most part, most people like the feeling that they have from their epidural. But not everybody does. So moving on to the risks. Everything we do has risks. Getting pregnant had some risks. And epidurals do have risks. So risks can be a difficult thing to interpret. And actually sometimes we're not very good at explaining what various risks are. You can explain them in a percentage terms. So meaning if you were to take 100 people, how many percent is that? Or we can say 1 in every so many people, which is often the way that you'll hear risks quoted in medicine, because it can cover a wide range of people. Sometimes people will equate it to everyday things, such as the same likelihood as one person in a football stadium or one person in the street. For the purpose of this, because it's the common way that we discuss risks for epidurals, I'm going to do it 1 in 100, 1 in 1,000, 1 in 100,000. So that means that if you were to give 100,000 people an epidural, it might happen one time. Okay? So, about 1 in every 100 people get a very bad headache after an epidural. Now this can make you feel terrible if you have it. However, for the most part, it will resolve on its own. There is a small percentage of people that this headache needs something else done, and there's a tiny, tiny fraction of people who can maybe have the headache forever, although that's very difficult to study the likelihood of that happening because it is very rare. The other common things that occur is itch, because one of the drugs we put in an epidural is well known to cause itch. For the most part, it doesn't usually cause too much distress, although a small number of people it can be really annoying. Epidurals have a failure rate, and in terms of taking away the pain for labour, probably somewhere in between 1 in 8 and 1 in 10 don't really work the way that you would want them to. That's often that they've worked more on one side than on the other. This is often because the little plastic tube that we put into the back that forms the epidural coils up. And if that coils off to one side, the local anaesthetic and other drugs stick to that side and don't go into the other side so well. Now sometimes we can fix that, but a percentage of people we can. The other thing is, labour pain tends to be in the tummy, but some people can also get it in the back. And sometimes that pain in the back is more difficult to get to go away with epidurals. So it's one of those things that occasionally that persists or persists for longer. As I mentioned, there are other things that you can sometimes feel during epidurals, and one of them is occasionally people can develop a temperature with it, and that's a temperature above 37.5 degrees Celsius. Temperatures above 38 are relatively uncommon, but usually a temperature within those two ranges can be associated with an epidural. The other thing is sometimes it can make you feel a bit shivery. You can develop a kind of fine tremor like this, which is just a side effect of the local anaesthetic. There is an association between epidurals and instrumental deliveries, but not caesarean sections. By that, I mean that if you were to study people who have epidurals and you study people who have forceps deliveries, there is a link between the two. Nobody really knows whether epidurals make it more likely for you to have a forceps delivery, or if your baby was in an abnormal position, you're sorer and more likely to ask for an epidural, but certainly there is an associated link between the two. A lot of people worry about nerve damage from epidurals, and it is something that can occur. You tend to find that minor temporary nerve injuries occur in about 1 in every 1,000 people. Those minor nerve injuries, such as a patchy loss of feeling or a difficulty in lifting the foot or something like that, probably occur in a permanent way in about 1 in 13,000 people. In terms of more serious injuries, such as paralysis, these can be caused by either introducing infection, what we call an epidural abscess, or causing bleeding, what we call an epidural hematoma. And the rate for these things is somewhere between about 1 in 100,000 and about 1 in 300,000. It's difficult to study because the numbers are very, very small, but it's very, very rare. And actually, if you look at the likelihood of these things occurring normally on their own without any epidural, they're actually not that far off the same risk from an epidural. They're just ever so slightly rarer. The other common association that people can have with an epidural is that it can numb the feeling to the bladder. And occasionally that means you need a catheter in. So that's certainly one risk that you should be aware of, although you will be relatively numb and you won't really feel it. The reason for the catheter is if the bladder over-distends, in theory it can cause damage to your bladder. So it's an important part of maintenance of how we look after epidurals. Now sometimes that's just an in-out catheter, it's not something that stays in. other times it's something that stays in. In terms of alternatives, epidurals are one of many, many things. There's gas and air that you breathe in and out, and a lot of women find that to be very successful. There's also intramuscular opioids. That's where you get an injection of a drug like pethidine or morphine or diamorphine. These drugs tend to make you sleepy and tend to make you care a bit less about the pain, but they don't necessarily diminish it, is what the research shows. But they can be used very successfully, and a lot of places around the world use these without major problems, although they do have some risks themselves, both to mum and to baby, which I'll talk about at a later video. If that's something you're interested in, please subscribe. Leave comments specifically about things that you might want me to talk about, and I'll talk about them in my next video. The other option that anaesthetists commonly do is a drug called PCA remifentanil, which is a type of opioid, and this is a thing that connects to a drip that we get you to press a button and it gives you a dose of very, very strong painkiller, and that is usually a step up from the intramuscular opioid, but not quite as effective as an epidural, although a lot of places use it with good success. But they do have upsides, they do have downsides, and they have some cautions to how we can use them. The other alternatives would be things like hypnobirthing, aromatherapy, TENS, which are some stickers that go in the back that pass a very, very fine electrical current to stimulate the nerve cells that control touch, and this can sometimes diminish pain. It's also why you find that when people come in labour, often they find that their partners rub their backs and makes them feel better. TENS works in a similar way, just in a slightly more effective fashion. And a lot of labour units have a hydropill that you can use when you're in labour for having a water birth. So ultimately, is an epidural right for you? One way to look at it is to think about it and think about what sort of things you might like and write a birth plan. This can be a way of reminding yourself of the things that you thought about before you were in labour. You can also try things in a sequential way, although you don't have to. So you can try things out of sequence, or you can go paracetamol, gas and air, intramuscular opioids, epidural, or you can chop and change in between things. Whatever is the best for you. Midwives are very experienced. Most of them have done this a really long time, and they're there to help you through this process. It would be really in your best interest to talk to your midwife about this and ask them their opinion, ask them about the progress of your labour, ask them about what they think would be good for you, because they're definitely there to be a professional, but they're also there to be a friend and to help you through this process. You can ask your obstetrician, especially if you're in a labouring consultant-led unit, because you might be there because of having slightly different risks. If that's the case, chatting to them about what might be a good and what might be a bad form of pain relief can also be useful. Consultant anaesthetists or anaesthetic registrars can also be around, and you can either come and see us in our clinics, because often most places have an antenatal clinic whereby we can see you in advance of labour and talk you through all the different options. But alternatively, we're on call and we're available to have discussions about pain relief 24 hours a day. So if you have questions, we're always happy to come and talk to you about it and go through what the upsides and downsides of different things are. Although partly that's the reason why I've produced a video like this, to help you think about these things in advance. Ultimately, this is all about you, and the idea is that we do what you want us to and what's best for you. The best thing to do is think about it in advance and come up with some ideas and some options and write it in your birth plan. I hope to see you in the next video. Please like, please subscribe. If you hit the bell icon, it'll tell you when I've produced another video. And if you want to leave some comments, as I said before, about things that you might want me to go through, that would be super helpful. Until the next time.